Okay, now we're going to go to a totally different setting, and I'm very pleased to be able to introduce someone actually you met this morning, Gary Darmstadt, who's probably our newest professor of pediatrics because he's been here less than a month. And he comes to us from the Gates Foundation, where he was a senior fellow for global development and really led the cross-program learning and integration projects that were involving women and girls. He's formerly an associate professor and founding director of the International Center for Advancing Neonatal Health in the Department of International Health at Johns Hopkins. And he trained in pediatrics at Hopkins, in dermatology at Stanford, and in infectious diseases at University of Washington. Gary?
Tom, thank you very much. And it's fantastic for me to be here. I've really enjoyed hearing about all the great science and innovations that are going on here and with other colleagues that are joining us. And my job is to try to take that science and translate it into a form that people around the world in the poorest parts of the world will take that information and put it to use, and that it will bring benefit to them. Back in 2005, I was part of an effort creating a Lancet series that summarized what is the global evidence around saving newborn lives. And we came up with 16 interventions at that time that were life-saving. And our analyses suggested that those interventions put together, delivered at scale, could save 72% of newborn lives around the world. We repeated that exercise and expanded it this past year. It's now up to 59 interventions that we have in our armamentarium to save newborn lives. I've shown some of them here with their really impressive efficacy. And these could avert 71% of newborn lives, according to those calculations. Well, let's consider one of these in just a little bit more detail. This is Kangaroo Mother Care. This is a very simple, almost no-cost intervention involving the mother holding a baby skin to skin, providing warmth that promotes breastfeeding. Tremendous potential to save lives. Estimated that we could save about 400,000 newborn lives around the world if we could scale this up. But guess what? The global coverage is less than 5%, and it's been there for 35 years. It's not going anywhere. Well, in that context, how are we doing globally? Are we really delivering on the promise of all this science and innovation that we're talking about? Here we see trends in neonatal mortality rate over time. The good thing is they are coming down, and they're coming down more quickly. But if you look at the newborn numbers in blue, you can see that the annual rate of reduction is only between 2 and 3% over the last 2 decades. And we've committed to bending those curves downward, to accelerating the rate at which newborn mortality is coming down. Are we going to be able to deliver? Consider this data here. This comes from the Community Empowerment Lab in India, in Uttar Pradesh, a very poor community, where a package of very simple preventive maternal and newborn care practices were promoted by community health workers, put entirely in the hands of the community, and then studied what happened in terms of changes in practice and the effect on mortality. And I would call your attention to these 3 practices here. Something really transformational has happened. If you look in the control clusters, we're looking at 10 to 20% adoption of these practices. In the intervention clusters, 70 to 90%. And these things came together to reduce neonatal mortality by 52% over a 16-month period of time. So how did this happen? Well, when I go to a place like India, I have to recognize that I come from a Western biomedical point of view. And in fact, most of the people who are designing programs, even in developing countries, policymakers, the program implementers, have tended to be Western educated, or at least have Western influence in their education, and have some adoption of a Western mentality, which looks something like this: that man is at the center, that I am powerful, that I can use my mind to deconstruct things in my environment. I can understand them, I can control them, and I can create new solutions that give me great power and great ability to control my future, to shape my future. But when we go into these traditional communities, we're dealing with a really different mindset that I think it's critically important that we recognize and think about how do we enter into this system effectively. There, man is seen as minuscule, part of a large circle of life, living in a world that has many different influences that are rather mysterious and not really under our control. And that what we see is really only a small part of reality. And that the only way that we can really effectively shape our future in any way is by banding together. And collectivism becomes really important, and our interpersonal relationships become extremely important. Well, in this context, when we went into this community in India, we decided to try to rid ourselves of the biomedical conventions that we knew, and to first try to understand what are the basic ways in which they are thinking about newborn health and their basic beliefs and principles that are guiding what they do. And let's start from that standpoint. And we actually realized that we had a lot in common, that they intuitively got the epidemiology of newborn mortality. They understood that the first week was an extremely risky period of time, and so they really focused on that period. And as a result, there are some practices around that of sequestering the newborn and the mother away to try to protect them. They also believed that what they were doing was actually the best possible things that they could do to save the lives of those newborns. And they had developed these practices over hundreds of years and passed them down. They believed that when illness and death occurred in a newborn, it really was a supernatural event, supernatural causes that were taking over. And there was a very strong belief in ritual pollution around childbirth. And so then when we began to look at the practices, we could map them to these underlying beliefs, things that were done to try to ward off the evil eye, evil spirits, to protect that newborn and the mother, and things that were done to try to rid the ritual pollution that the mother and the baby were born into. From our biomedical standpoint, these then became opportunities to begin to think about how we might intervene. But they actually mapped to risk factors for known causes of death in our minds. The baby becomes sick from those risk factors. There's delays in care seeking because you're essentially trying to hide away in a small room in a home where the baby is born or brought to soon after birth to protect. And so there are delays in care seeking that all add up to a baby dying, to us a failure. But to the community, they've been successful. Although the neonatal mortality rate here was 80 per thousand, there are 920 per thousand that are successful events, reinforcing their beliefs that what they're doing is actually very helpful and reaffirming what they're doing. So as we begin to think about how to intervene, there are a few key principles that we tried to keep in mind. One is that it's got to be believable. It has to fit into and build upon existing knowledge and the framework through which they think. And we favored actions that would have visible effects, something that people can actually see that what they're doing has created some kind of response that gives them a sense of control. Given their worldview, we thought it was extremely important to package everything together under a unified concept and make it as simple as possible, and to leverage existing learning pathways that they use to transmit new knowledge. And then to transmit knowledge into skills that they could actually take up to give them a sense of self-efficacy. So some key observations that guided us as we were in this community thinking about how to intervene. We noticed that the practices that were associated with risk for infection were also associated with risk for hypothermia. We don't have time to go through all of those, but just for example, if a baby is born onto the ground that has been covered with cow dung as a purification exercise, and then that baby is left there, not being dried off until the untouchable woman who can come and deal with the pollution and not become more polluted herself, They wait until the cord is cut and then the baby is dried. Huge risk for both infection and hypothermia. They had very well thought through concepts around hot and cold, and it permeated so much of their life, their food, many of the practices. But we noticed that they lacked a word in their language that would link exposure to cold in a newborn to some kind of ill effect. It wasn't in their vocabulary at all. And we also noted that around breastfeeding, most babies were not being breastfed until the third day of life, maybe some of them on the second day. And we came to learn that what was happening is that the families were consulting the priest at the time of birth and asking the priest to recommend the auspicious time that they should begin breastfeeding the baby. And they typically would recommend day 3 or day 2 after consulting the stars, reading the astrology. So these became the action points based on this knowledge that we had gained. We saw hypothermia as really a unifying concept that touched upon all of the practices that were going on, and that again was also linked to prevention of infection. And that this is something that could be manageable and could give the people a sense of control. And set out with the community, and they actually came up with this word. They created a new word in their vocabulary, cold fever, which gave this connotation that cold can be bad for your health. And that seemed to really ignite their imagination around what might be possible, and began to give them a sense that maybe we can do something about this. Maybe it's not quite so mysterious. Then worked with the chief priests to build some trust with them. And there was one chief priest who doubled as a village doctor. And he had spent quite a bit of time observing physicians and had a sense about their practices and knew that immediate breastfeeding was very important and good for the baby. And it came to the point that the team engaged with him and said, you know this is the best thing. Could you change your practice, and could you recommend it be implemented immediately? And he said, yes, I will, but beyond that, I will talk to the other priests and I'll make sure that they do the same thing. And so breastfeeding in that community was transformed in one day by going through this village doctor. That opened the way for skin-to-skin care to be introduced. Now that breastfeeding was allowable from the very first day, skin-to-skin care was something that the women could take on. Up until that point, they had been keeping the babies at a distance because of the embarrassment that milk let down, and not being able to breastfeed your baby in response for the first few days led to distance between the mom and the baby. But skin-to-skin care bridged that. They were able to provide warmth and breastfeeding immediately, and they noticed that the babies cried and startled less, which was immediate feedback to them that was super powerful, because they perceived the crying and the startling of the baby as the baby recognizing that an evil spirit was lurking, and would cry and startle in response to that. And when that went down, they felt like, wow, this even has power over evil spirits and keeping them at bay. And so it became something they really wanted. It then became a matter of aligning the priests and the various stakeholders within the community. And then just very quickly, the final translation of the science into their culture was a series of simple messages that related to their daily lives. When you come out after a dip in the pond, if you just wipe your face, won't you feel cold? Similarly, if you just wipe the face of the baby but the rest of the body remains wet, the baby will feel cold and will develop tanda bukhar. Now, does that seem like a super powerful biomedical intervention? It actually was super powerful. Wiping the baby head to toe at the time of birth changed from 18% to 93%. Another example around skin-to-skin care, it was promoted for every baby. The message for preterm babies was to quickly ripen raw mangoes, you cover them with a straw to keep them warm. A preterm baby is like the raw mango and needs to be kept warm to develop faster. Again, super powerful medical intervention. Changed from 10% to 85% adoption of skin-to-skin care, and again, this came together to cut neonatal mortality in half. But that wasn't the end of the translation of the science into the culture. The community actually took it up, and they did the best job you can imagine themselves. If we could play this video, you'll see just a brief clip. So this song goes on for a long time. And all of the messages that we had brought to them were all woven into this song in a way that you can see people of multiple generations, men are surrounding, watching all this. They're all getting enculturated, getting onto the same page. Immediately takes care of adoption and takes care of sustainability. So I would submit that this is extremely important for advancing our ability to save lives in poor parts of the world. Thank you.